necessary. Mothers with complex medical disorders are often cared for in general hospitals with access to intensive care. So therefore it is imperative that all recognised licensed hospitals should be able to provide these life-saving procedures. Where neonatal care is not available to care for a very premature baby, and provided that the woman's health allows, in utero transfer pre-delivery to a unit that has appropriate facilities should be considered. This is established current practice currently in Ireland. 6.7 formal review process. It is the Institute view that the medical model at the woman's request or by another person acting on her behalf is the preferred option. 6.7 composition of the review panel. It is the Institute view that all specialties are to source and provide from within their appropriately qualified ranks consultants practising in Ireland to form a panel that can be called upon for a second opinion. There should be a minimum of 2 obstetricians gynecologists plus other specialties similarly qualified as appropriate. In obstetrics and gynecology, the Institute would act as a list provider. The panel should be indemnified against possible subsequent legal proceedings and have access to formal legal expertise. 6.7, the convener. With regard to the convener, it is the Institute view that a nominated person or department in the Department of Health to whom the woman can access directly should convene the panel from the list supplied by the professional bodies. 6.8 and 6.9, access to courts for appeal and conscientious objection. These were acknowledged as read, and in the latter case, it was noted that this may extend to other health professionals. 6.10, monitoring system, monitoring review panel. It was the view that these important cases need close monitoring and regular review. Chapter 7, options for implementation. In regard to this question, it is the view of the Institute that statutory legal protection is required for healthcare professionals and their patients. 7.4, alternatives for implementation. It was the view that 7.4.3, legislation plus regulation, provides the necessary flexibility and protection for healthcare professionals and their patients. In conclusion, we are very grateful to have the opportunity to participate in the discussion. We respectfully request that the Institute have input into the final wording to ensure that we are allowed to continue with current practice, which includes the provision of life-saving treatments to pregnant women.
Thank you very much indeed. It's now in the realm of members for 60 minutes, and I'll call on Deputy Kelleher.
Just 2 brief questions. First and foremost to Mr. Niall Behan of the Irish Family Planning Association. Just in connection with the submission that was made with regard to the services you provide and assisting people in the decision that they make, and we obviously know that it's very complex and many decisions or circumstances can arrive where a woman decides that ultimately a termination is what she feels is the most appropriate for herself. But just in the context of and listening to the previous psychiatrists and their analysis and interpretation of statistics and facts, and there was even some divergence among those eminent people as well, do you assist people in terms of accessing psychiatric services first and foremost, or would you consider that if a person has made a decision to terminate the pregnancy for mental health reasons, for suicide ideation or intent or otherwise, would you make a suggestion that maybe initially some form of psychiatric support would be the most appropriate means? Because the evidence so far to date from the psychiatrists would suggest that intervention does assist as well, and that is not necessarily a termination is the actual correct method at the end of the day. If a woman is given assistance, ultimately she may decide that a termination is the only option for her, but at least that she will be given support. In the context of the Institute of Obstetricians and Gynecologists, on the issue of lack of legal clarity, have you in your professional capacity ever had a difficulty in arriving at a decision to intervene and interrupt a pregnancy to save the life of the mother? We hear a lot about the fact that it is seldom carried out as a procedure to save the life of the mother. We talk about maybe between 20 and 40 times a year. There's still varying views as to how many a year are carried out, interruptions. But have you ever found in an actual circumstance where you felt that you could not intervene at a particular stage to save the life of the mother because of lack of legal clarity or the threat of the 1861 Act, Section 58 and 59, whether or not that has impacted in your professional capacity to intervene in saving the life of the mother.
Deputy Kevin O'Quilla.
I'd just like to join in welcoming all of the panellists here this evening. To address Niall Behan's contribution, first of all, if I may, on behalf of the Irish Family Planning Association, I note in the submission, Mr. Behan, that you have, in my opinion, very correctly pointed out, and a number of colleagues have already expressed the concern that oftentimes the first point of contact is with the local GP. And sadly, they're not a part of the opportunity over these 3 days. The experience of the IFPA and of many doctors is that medical service providers in Ireland are prevented from acting in the best interests of pregnant women's health and must navigate the grey areas of the law, is how you've put it. I think that that's an important point to make. When you go on to talk about those who avail of your services, you speak of the fact that a small number present where the risk to their lives is real and identifiable. Of those that did, you've indicated that a very small number again, and this is consistent with all of the evidence we've had, had suicidal ideation or intent. Can you give us any indication at all of the numbers of those who might have attempted suicide over the period of time? I'm hoping that unsuccessfully would be the point to add. And can I just ask you finally, do you think it's likely that women who have the financial means and who have either suicidal ideation or suicidal intent will continue to travel in order to access abortion services rather than face the psychiatric services within this state? Is that something that you would recognise? In relation to Professor Green's outline, it's broadly statistical. I think it's fair to say from the MDE situation. I welcome the statistics that you've shared with us. You haven't drawn any conclusions per se in terms of your contribution, either in writing or orally here this afternoon. I wonder, would you like to elaborate in any way, particularly in relation to Table 2 and the comparisons with other international settings? Are there conclusions or views that you would deduce from the information presented in Table 2? And finally, if I may, and time beats us here all the time, but I'd like to welcome the representatives of the obstetricians and gynecologists, and thank you, Professor McAuliffe, for your contribution. Just one little clarification. When you make the point that you believe it would be appropriate in given circumstances that general hospital settings could be appropriate settings for particular decisions to be taken, and that's outside of the remit of obstetricians and gynecologists. Many of these general hospitals would not have maternity units. I wonder, would you elaborate on that, please, and just give us a sense of the situations that you would see appropriate to that particular point that you shared with us in the course of your contribution? Thank you very much.
Thank you. Senator Deputy Ciara Conway and Laska Hirach.
And to thank all the contributors for their evidence thus far. I just have a number of questions. Firstly, for the Institute of Obstetricians and Gynecologists, and how you deal with minors and young girls who present as pregnant to your services. And I suppose we had some discussion about it earlier with the psychiatrists, and I just would like to get some clarification for the committee. That is it the case that medical consent is can be given by somebody at the age of 16 and then the anomaly that throws up in terms of somebody being recognised in law as a child up to the age of 18. And what your procedure is for maybe making a referral, an appropriate referral for that child and the incidents, because we heard from Professor O'Keefe in the last contribution that pregnant teenagers are at a much greater risk of dying by suicide than non-pregnant teenagers, and maybe just to get your real-life experience in relation to how we deal with young people, children and adolescents when they present in your clinics. In relation to the maternal death inquiry, again, I would ask, of the recorded maternal deaths, were any of the women who died tragically underage? Were they under the age of 18? And maybe you'd share that information with us. And again, to focus on something that just to go back to the obstetricians and gynecologists, about the composition of a review panel and the convener and the points that you make in relation to that. I suppose what I'm looking for is, how in practice is that going to work? Because I have a vision of a woman who's in crisis, or a young person who's in crisis, and I have a vision of, well, you have to put your crisis aside now for a couple of days or hours or weeks, or what is it going to actually physically look like in terms of going to get a second opinion from the review panel by contacting the convener. How is that actually practically, do you envisage it working for practitioners and for people in receipt of the service? Because the European Court of Human Rights, as Niall Behan quite correctly pointed out, made the recommendation that whatever we do, it must be tangible and it must be practical. It can't be theoretical and cumbersome, particularly for women who find themselves in crisis.
Thank you, Deputy. And lastly in this segment, Senator John Crown.
Just a quick question really for, well, possibly a series of short questions for Professor Green, just for the benefit of my colleagues who do not have a background in interpretation of medical and epidemiological statistics. I was wondering if you just might care to elucidate a little bit the difficulties which occur in attempting to draw conclusions statistically when you're dealing with such very small numbers. A number of statements have gotten out into the lay media suggesting that you could define a cause and effect relationship between the availability or non-availability of abortion services in the country and its maternal mortality rates. I would be very troubled by that supposition, based on the fact that maternal mortality is such an extraordinarily rare event that it is indeed very, very hard to make any kind of causal statements with regard to other potentially confounding factors. Also, it has been frequently suggested that not only are we one of the best countries in the world, safest countries in the world from the point of view of maternal mortality, but that we're number one. And it has been suggested that we're number one for a reason, and that reason is somehow that because we don't have legalized abortion, that we have a higher rate of maternal safety. I was wondering if my colleagues, and I'm sorry I'm being slightly repetitive, from the Institute again could just clarify this. I've been asking this question repeatedly of professional representatives today. Are we aware of any case in the history of this state, and please, I'm not trying to stray into individual cases or to ask for any editorializations about contemporary cases, is there concern that there ever has been a case in this state where a woman died needlessly as a result of the legal vacuum surrounding abortion? But we'll say even in the last 30 years, since the issue came onto the constitutional horizon, has it ever happened? Also, would the Institute be making a recommendation that there should be a very specific and relatively liberal regime for making emergency decisions with respect to the need for abortion when the mother's life is in danger? And I would ask our colleagues from the Family Planning Association if they could perhaps, their role in giving post-abortion counselling has become an issue. And again, it's not specifically...
The specifics of what we're dealing with today, rather than straying in that area, please.
Okay, I would try not to stray into any other areas, but you do provide post-abortion counselling service. I just wondered if perhaps you would clarify for us, in the event of a legal change, how you would police the medical veracity of what is said to clients who attend your clinics. Thank you very much.
Thank you. Professor McCall, if you might want to start, please.
Okay, so to address Mr. Kelleher's question about the lack of legal clarity, we feel strongly that it is in the patient's interest and the public interest that doctors work within a legal framework. Just to clarify, if a woman has a substantial risk of dying in the immediate hours or days, there's no legal difficulty. We press on and offer treatment. However, I am aware of cases where there is a substantial risk to her life. It's not immediate. There is legal uncertainty, and we have referred those cases to the UK for treatment. Mr. O'Quailon, in terms of clarifying the general hospitals and termination of pregnancy, most of the cases we're dealing with are patients with severe medical disorders. So many of these patients need access to intensive care units, to physicians and so on. So an example would be, we'll say, a patient with a deteriorating heart problem. They would be in coronary care in a general hospital. And if a time came when we felt that termination of pregnancy or indeed delivery of a very premature infant was required, that would happen in the general hospital because the maternity unit wouldn't have the facilities to look after that patient. So that's why we feel strongly that the general hospitals need to be included. If, for instance, the woman was in a general hospital in an intensive care unit and deteriorated suddenly and needed delivery of the baby, there wouldn't be time to transfer to maternity unit. It wouldn't be safe to do so. So that's why we feel that these procedures, these life-saving procedures, should be carried out in all hospitals. But because most of our patients are medical patients and they need access to intensive care unit and the physician input, many of these are being looked after already in the general hospitals. Will I keep going?
Sure, yeah.
Yes. Ms. Conway, just the question about the minors. So the age of consent is 16. So if she's over 16, we deal with her like any other patient. If she's under 16, then she needs to have a next of kin. Thankfully, our rates of teenage pregnancy are relatively low in Ireland. So the situation, if she was very medically unwell and she's under the age of 16, well, then we would require her next of kin to consent on her behalf. If she's very unwell, of course, we're going to go ahead and give her treatment as we would. So if you're looking at somebody who has substantial risk of a life-threatening problem, they're going to be receiving intensive treatment, either psychiatric treatment or medical treatment. So that treatment will continue. And then the issue of delivering the baby earlier, of termination of pregnancy, if she's under 16, would then be, we would require the input from both her and her next of kin. In terms of the review panel, how it would work, I suppose the first thing to say is any of these patients we're talking about are usually receiving intensive medical treatment. So that treatment is ongoing. And the issue of the termination of pregnancy or delivering the baby early is part of that package, but the other treatment is going to go on in the background. I would agree with you, we need a review panel that would be timely. We discussed this at the institute level, and that's why we felt that there would be a panel already available, not of 1 or 2 doctors, but of 10, 20, 30, so that you could quickly get an opinion, a second opinion, or if required for the review panel quite quickly. But I think the details will have to be worked out, but I would totally agree with you. I think we need something that will be timely and will be workable. And I know the psychiatrists, for example, do have a system in place for a second opinion. That might be a structure that we could look at for this. Dr. Crown, in terms of do I know of any woman that died because of the lack of the legal vacuum? No, I'm not aware of any case. As I've said already, if a woman is imminently in danger, we press on and treat her. In terms of the emergency, I suppose one of our concerns here is that if a woman is really very unwell, we do not want doctors to delay treating her, having to get 2 consultant obstetricians plus or minus physician, filling out paperwork, and meanwhile she needs to get on and deliver the baby, either before or after viability. So I'm not suggesting I'm not suggesting any great change in practice. If any woman in any hospital around the country pregnant is very, very unwell, she will get that treatment. But I think it's important that doctors feel protected, so in the emergency situation that they can get on and deliver that emergency treatment.
Thank you. Professor Green, and the questions relating to you, if you may.
Thank you. First of all, to Deputy Quailon, with respect to no conclusion, I think what I was putting down was a factual account, the most recent and, I suppose, detailed account of maternal mortality in Ireland. And the only conclusion I can draw from it is that when we do that, we actually have figures that are substantial, that are very good in comparison to the rest of the Western world. And I think it is a marker of the healthcare provided to women in Ireland. I suppose in another conclusion and in partial response to one of the questions from Senator Crown, that the issue of we being sometimes called number one, or at least we're in the top in the top few with respect to maternal mortality. And people claiming that that may be because we don't have termination. I think that I don't have evidence to support that in any way, and I don't think that that's evidence that will stand up if you look internationally at literature on maternal mortality. In fact, we have many developing countries who have termination and have maternal mortality rates in the order of 800 to 1,000 per 100,000. We have countries in Europe which are within the same region in terms of maternal mortality as ourselves, which have similar, who have termination of pregnancy, both, if you like, social and medical termination of pregnancy. So I don't think that those kind of conclusions can be made. I think that what we're looking at is the fortune of an educated, well-fed, healthy population with good medical health care, of which includes a component of, as Professor McAuliffe noted, where we undertake terminating pregnancies appropriately to protect the mother's life. In response to Deputy Conway, with respect to the question about any women under 18, the answer is no, thankfully. With the further questions about clarifying the statistics, statistically, when we look at, on table 2, we actually give the figure of 8.6 per 100,000, and we actually show what's called a confidence interval just thereafter, which basically, if you take that figure on average and you worked it out statistically, we would be talking about no difference between 4.7 and 12.4, that we could be anywhere in that group of figures and we'd be the same. So therefore, we're not that dissimilar from the UK, effectively, is what those statistics are showing.
Thank you. And Mr. Bean, questions regarding to you?
Yeah, I'm just going to take the first question from Deputy Kelleher about the issue of women who might present, who might have suicidal ideation. And certainly in first instance, if they were already attending a psychiatric service, they would be encouraged immediately and facilitated to actually liaise with that psychiatric service before making any full decision. If somebody presented who was not in contact with any service at all, we would seek, if possible at all, to liaise with their GP to try to arrange for them to have appropriate care before they would make a decision. In the event where somebody is absolutely certain and has already come to their decision and doesn't wish to do any of those things, we really need to try to, it's always an individual case of trying to add up what is in that person's best interest. But overall, our idea is to try to liaise with psychiatric service or general practice services to actually assess the woman and help her with her mental illness. And just in relation to Deputy O'Quailon about whether or not women might still choose to travel, I think that is going to be very individual, and I think some women would still choose to travel even if they felt that they might meet the criteria, because they might just not want to either have the delay or to have the problem of going through the assessment. But I think some women, on the other hand, who are in that position and who can't afford to travel would certainly be very much able to be facilitated by that service. Okay.
Yes, just in regard to Deputy O'Quailon's question regard to our two clients who had attempted suicide. Thankfully, they were unsuccessful in their attempts. We had those two cases happened within the last 3 years, and that's as far back as we looked. One of those clients specifically mentioned the barrier to a particular barrier to being able to travel to the UK for an abortion as one of the reasons why she attempted suicide. With regard then around kind of accessing psychiatric services, certainly both abortion services and mental health services are still very much stigmatised in Ireland, and many of our clients express strong views around that. And they talk about the personal and social implications of actually accessing both abortion services and psychiatric services. So certainly it's our experience that that women who are not involved in the psychiatric services and they want to travel for a termination to the UK, they'll travel to the UK in preference to being kind of stigmatised, or as they would see it, stigmatised with a mental health illness. With regard to Senator Crown's question, you know, the IFPA has a range of stringent policies and procedures in place for our services, and if there's a specific complaint made to us and it's apparent and it's verifiable, you know, we can deal with that. We're in a situation where, you know, we've been in contested areas of, you know, public discourse and providing services for the last 40 years, you know, and it's always been like that for our organisation. So, you know, we have to have those policies and procedures in place.
Thank you. Okay, our next, we have a number of speakers offering now, so I'd ask members to be brief again. Senator Burke. Senator Burke, yeah.
Okay, thank you, Chairperson. It's just a question to the Institute, and it's in relation to the options set out in the expert report. And I've asked this already this morning, and I'm just looking for clarification. There are 3 options given in relation to the decisions that have to be made by psychiatrists. One was that there would be two psychiatrists or 2 people from a particular specialist area. The other option was 1 from the specialist area, or 1 psychiatrist plus an obstetrician. And the third option was that 2 people from the specialist area, or 2 psychiatrists plus the obstetrician. I'm just wondering, what's your view where it's an issue of suicide as regards whether the obstetrician should be part of the decision-making process on that? That's question number 1. Question number 2, it's in relation to the smaller units and the fact that in the smaller units, from 5 o'clock on a Friday evening to 9 o'clock on a Monday morning, there's only 1 obstetrician on call. And I'm just wondering, you know, the procedures that are there at present and the procedures that she would like to put in place to give support to where a decision has to be taken by an obstetrician, in particular where at weekends, where that's the situation. And the third issue relates to the smaller units as well, where in a lot of the smaller units, it's a locum that's brought in, especially, for instance, during holiday period, where a locum is brought in, is work 8 weekends. What support levels would you suggest for putting in place to deal with an emergency or with a situation where decisions have to be taken to terminate a pregnancy?
Thank you, Senator. Senator Amanda-Henry.
Chairperson, thank you for your presentations. We're here today to legislate, and we're going to spend the next 3 days listening to medical, legal professions and other groups putting their viewpoint across on a very complex issue. And I suppose what's really important is the wording of the legislation. And I hope after, when we do come to actually going through with this, that the wording will be correct and that the medical profession will have support when they are legal support when they have to make a decision to terminate a pregnancy in the very rare circumstances. And can I just say that we have to trust our doctors and our medical professions. And you know, we heard from the masters of the big maternity hospitals in Dublin, but can I just say that we have wonderful maternity hospitals right across the country, and in particular in the west of Ireland. And I'd like to welcome you, Maeve, from Mayo General. And I know myself that I had a rare disease, and I'm very lucky to be alive. And I don't think of you every day, Maeve, but from time to time I do. And I'm very glad that you did stay in the west of Ireland and are so involved in your profession. But I do want to say, I don't have a question, but I am disappointed that we don't have somebody from the GP Association here. And I am, because I know that sometimes, or from the IMO, sometimes when you go to your GP and you're troubled or whatever, if you're pregnant, you may not go any further. And there are, and I know in Sligo, that GPs have referred people to the Mary Stokes Clinic in Belfast. And I want to put on the record, I'm disappointed we don't have anybody from the IMO here.
They were invited and they declined to come in, just as you know that. Okay, Deputy McGrath, you have 2 minutes.
Cahill, I too want to welcome our guests here today and thank them for coming and giving us their views, and I thank the medical profession especially. And I too am disappointed we haven't doctors, but at least they were invited, so there are other people that weren't invited and they're not happy. I want to ask a question really to the IFPA, and their website states that it believes that abortion is an aspect of private life and reproductive rights. It states further that the IFPA supports the choice of access to termination during pregnancy in all circumstances. This makes the IFPA, which is partially taxpayer funded, an abortion advocacy group. Considering that you support choice in all circumstances, do you think that the unborn child is entitled to any protection under law? And I'd also want to just query as to the kind of consultation that the other groups had with their members. How did you consult? Because I'm being told that people are complaining they weren't consulted, and that's unfortunate if that's true. And I also want to say from my own perspective in South Tipperary General Hospital that with top-class facilities, all my children were born there, and I want to thank you in general for that excellent delivery service from the midwives to the doctors to everybody.
Thank you, Deputy. I think it would be unfair to say that the IFP are an abortion advocacy. They're a sexual health reproductive rights organisation, to be fair, I think, to put the record right.
Can answer the question.
Deputy Fitzpatrick.
Planning Association provides information and support to 5,000 women and girls experiencing pregnancies. First of all, I'd like to know is how many had suicide thoughts, and the second question is how many committed suicide. And I'd also like to ask is the Irish Family Planning Association, what support was given to these women and girls? You've also stated here that women and girls in Ireland who require abortion services experience stigma and discrimination and receive a lack of support and information from the state. I wonder, can you give me more? Could you elaborate more on that there, please? Thank you.
Thank you, Deputy. Deputy Naughton. I take all the speakers now together just so that we can allow.
Thank you, Chairman. A number of the questions that I wanted to ask have already been asked, but can I ask Maeve, when she's responding, if she could respond to the questions raised by Colin Burke, because they're very relevant in the west of Ireland. Could I ask Niall Behan in relation to his particular presentation? You made the point that you do cater for 5,000 women on an annual basis, and you said in your response earlier that you had 2 cases of attempted suicide in a 3-year period. Now, we had Professor Veronica O'Kane here with us earlier on. She was making the point that the level of threatened suicide and suicidal intent and ideation is far higher with the frontline services who are meeting a lot of the clients rather than the perinatal consultants. Now, the figures that you have provided here, and you see an awful lot of women, seem to tie in very much with the perinatal consultants rather than the figures given by Professor O'Kane. So if you could just clarify that. If I could ask Professor McAuliffe, just if you could clarify for me, you're saying that there should be no special provision in relation to emergencies. I presume what you mean is in reference to the expert group report, when in fact what you're actually looking for is special provision in relation to emergencies, that the current procedures would continue to be provided for and that they wouldn't come under the terms of any new legislation and wouldn't require a second consultant to write off on it. So in fact you are looking for special provision in the legislation for emergencies, but not special provision as outlined by the expert group report. If you could just clarify that that is the case. And just the final question then to Professor McAuliffe and Dr. Niamh Bhreathnach is we've 120 consultants in obs and gynae in the country. Are you satisfied that there is an adequate geographic spread of those consultants around the country to ensure that all of the existing maternity facilities can provide these services and can make these decisions in the difficult situations as they may arise?
Thank you. Deputy Seamus Healy.
Thank you, Cahill. Look, most of the questions have been asked, really. But just one question to the Institute. You know, we're dealing here on the basis of the probability of a real and substantial risk to the life of the mother. Excuse me. I'm just wondering the view of the Institute on the whole question of fetal abnormality, and how does that come within the real and substantial risk to life, or does it come in, and what are the views of the Institute on it, please?
Thank you, Deputy Dowds.
A question to Professor McAuliffe. You mentioned about referring some of your women to England. Could you clarify why that is, how many, and does it relate to the inadequacy of our current legislation?
Thank you, Deputy. And Deputy Regina Dart.
Thanks. It's to follow on from Deputy O'Dowd's question to Professor McAuliffe. You mentioned earlier on that when the substantial threat or risk to the life of the mother is immediate, you know exactly what to do as professionals. But when it's not immediate, there's obviously a very grey area there. And you mentioned in your presentation earlier on that in certain scenarios you're sending, that category of women to another jurisdiction to be treated before they come back. In framing legislation, if you were to determine that that category of people were included, what suggestions would you have, or how would you advise for those people whose threat to their life isn't immediate, as in now? How would you suggest that we include that in the legislation?
Thank you. And finally, Deputy Catherine Byrne.
No, it's just a little point of information, really, and it's around. I'm glad to hear that Ireland is probably one of the safest places to have a baby. But I just wanted to ask the Irish Family Plan Association why in their submission have they enclosed a number of European countries' legislation? Was it specifically just for information, or do you have a specific reason why you've enclosed the information? Thanks.
Okay, thank you. We have 29 minutes left in the session, so Professor McCall, if you want to start off, please.
Okay, thank you very much. Just to clarify with Senator Burke in terms of the two obstetricians. So we discussed this in detail, and we feel that all cases where it's felt that termination of pregnancy or premature delivery of the baby is required, that two obstetricians would be involved in that decision. If it's suicide, if it's heart disease, if it's lung disease, we feel that obstetricians should be central to all of this. So in answer your question, we feel that two obstetricians plus the relevant qualified specialist register psychiatrists. In terms of the consultation process Deputy McGrath brought up, we convened a group of senior Institute members on the 4th of December. We discussed the report in detail. We came up with a draft document. We circulated to the members of the executive of the Institute. We discussed that on the 14th of December. The executive members of the Institute represent their own regions. They're chosen from different regions around the country, and their role is to communicate with their members within that region. The document was passed unanimously through the executive on the 14th of December. So we feel that adequate consultation has occurred with the Institute members. In terms of the emergency, Deputy Naughton, what we're referring to there is that in an emergency situation in medicine, often usual procedures and policies would be put aside to prioritise the giving of medical treatment. So we would feel the same would pertain to if a woman's life is in serious danger, the concern about her life, she needs immediate treatment, that yes, one obstetrician would be sufficient. We wouldn't expect two obstetricians and the necessary paperwork to have to pertain, because we'd be concerned that women's lives will be lost in a process. So in an emergency, what we're referring to there is the usual clinical guidelines that pertain to emergencies, that people will often do their notes afterwards, and that the priority is to deliver first-line medical services. In terms of the fetal anomalies, the remit of the Institute was to give an opinion on the expert report, which was confined to a substantial threat to the life of the mother, and there was no remit there for the fetal abnormalities. So our brief is confined to that of the expert group. So to clarify, Deputy O'Dowd was asking about the legal framework. We feel strongly there should be a legal framework for us to act in these cases. The cases, I am aware, we don't have a registry of these cases. Because I'm a maternal medicine consultant, I'm a specialist in this area, so I see a lot of these cases. but there would be a number of these cases per year where there's a bit of legal uncertainty, and we would refer the patient abroad for treatment. I don't have exact numbers, but I think it's very important that we work within a legal framework. It's important for our patients, it's important for the public that doctors are working in an appropriate legal framework, and we would very much request that we get a robust legal framework from yourselves. In terms of how would we deal within that legislation, in terms of the immediate risk and so on that was brought up, we feel that that's where the medical expertise comes in. We have experience with looking after pregnant women. We know the knowledge of the literature, and our view is that if 2 senior obstetricians feel that there is a substantial risk to the life of the mother, and we're not going to define percentages or timelines because these are impossible, that will fulfil the criteria. So if we have in legislation that there's a substantial risk to the threat of the life of the mother, and 2 senior obstetricians feel that threat is there, we feel that the legislation will cover all situations that arise where there's substantial risk to the life of the mother.
Thank you. Dr.
I'm happy to answer the questions on the smaller units, and many thanks for the favourable comments on maternity service in the West at this time. Regarding the smaller units, it was dealt with at length this morning with Dr. McCaffrey in the chamber. It's a solo place. It's quite an isolated place out of hours, and unfortunately obstetrics tends to be busier out of hours than in hours. I think we've seen a huge change over the past 10 years since the review of the maternity services. There are informal networks linking hospitals all around the country for the maternity units in each area. Those networks are not formalised in every part of the country, but they do afford a greater communication between tertiary specialists who can be accessed. There's a lot more freedom with mobile phone numbers, with ability to contact colleagues out of hours. In terms of a consultant going off duty in a small unit, leaving the duty of care with a locum, the substantive consultant has a duty to ensure that the locum is suitably qualified for the services. We have some huge difficulties in staffing these units, but for the purpose of this discussion today, if the substantive consultant is not adequately satisfied that the locum can perform all duties that might arise, they would then not be able to go fully off call. Their response time might not be the 10 to 15 minutes for obstetrics that it often is, but they might be responsive by phone and be able to return from whatever their commitment is over the next 30 or 60 minutes, which in this type of discussion today is often the time frame that we're looking at. There is a recognised urban drift of professionals towards the urban centres, and in different working groups there is definite urban drift. It's very difficult in a country that doesn't focus on rural training and rural streaming for how these services are going to be delivered in the long term. But in practice, it is possible in many situations of imminent risk to get second opinions and to often get a second pair of hands. And you have to remember, at the moment all the maternity units are sited in a general hospital outside the freestanding maternity units in Dublin. So there are other specialties who haven't been involved in this process. There are general surgeons who sometimes come in some of the emergencies. There are general physicians who are in ICU. There are anaesthetists with intensive care considerations that are our teams when we're on duty at weekends. So the brief needs to be widened into other medical practitioners who will, of course, be governed under the Medical Council provisions that will change in due course as this House legislates. The consultant spread, are we satisfied that with 120 that we have enough geographical spread? That will depend on what happens with reconfiguration. So legislation the reason we've looked at regulation with the legislation is that we have to be able to adapt to the situation as it arises. And if a unit suddenly loses some aspect of its acute service, then the geographical spread might not be acceptable, and we might have to regulate for that to adapt as time proceeds.
Thank you. Mr. Bean.
Okay. First, if I start with Deputy McGrath's question around the IFPA, first and foremost, we're a medical organisation. We see 20,000 clients per year. The other thing is we've come to a particular position on abortion and around the criminalisation of abortion through years of kind of dealing with women who have come to our services, and we've come to the conclusion through this dialogue that it is it's best that these decisions are left between a woman and a doctor, and that criminal law really shouldn't come into that, and it doesn't serve any purpose in those discussions. And I think the big fear around that is that, you know, if criminal law is removed, that we'll have a huge increase in abortion rates. And what we know is that that's just not true. There's enough evidence there now to say that the criminal law doesn't actually impact on abortion rates. And I think that's why we included some of the information on what happens in other countries in our submission. We also included that because in the ABC judgment, the court actually suggested to the Irish government that we look to what happens in other European countries to resolve these very, very difficult issues. And we kind of look beyond what we usually do, is we usually look to England for an answer. And what they were saying is that maybe we should look broader than that. So that's why we included it in the submission. The other issues, I think, forgive me if I haven't got everybody's question, but the other questions I think related to around issues around suicidal thoughts and how many clients we saw. What I was actually saying in our opening statement was that we had 2 women who actually went and followed through on their threats to commit suicide. We'd have much more women may not be suicidal, but would certainly be looking at would see themselves as having a crisis pregnancy for mental health issues. And, you know, what happens, and even if, you know, on that broad range of mental health issues, from, you know, depression to kind of more severe mental health issues, right to kind of suicidal thoughts and threats, what happens to the vast majority of those women over the years? They've travelled to the UK. The other issue as well around the criminalisation of abortion and how we might respond to, and I think Deputy McGrath specifically asked a question, or was it Deputy Fitzpatrick, I'm not sure, around the unborn and where we see what have we got to say about the unborn. I think what we've got to do is we've got to look back at what has happened around abortion rates in Ireland over the last 10 years. And we see them coming down fairly substantially. And I think they've come down because the last time there was a hearing like this around the abortion issue, the parliamentarians listened to what a whole range of people were saying around the issue. And the issue is what they were saying, what the medical advice the parliamentarians were getting then was that to bring the abortion rate down, we need better sex education and better access to contraception. And from that, the Crisis Pregnancy Agency was formed, and that has been very successful in bringing our abortion rates down over the last 10 years.
Professor Green, anything to add? You're happy enough?
No.
Okay, thank you. We have 15 minutes left in this session. Deputy Curran, you indicated. Yeah, no, go ahead.
Yeah, just a couple of additional points, if I can, because my opportunity in relation to the obstetricians and gynecologists was very limited. I'd like to go back there, if I may, Professor McAuliffe. I would expect that the situation in relation to the 1861 Act, that it would be your professional experience and that of your colleague and colleagues indeed here, that there are no instances, to your knowledge, where the threat, the overhanging threat of that extant legislation, that it would have impacted negatively on decision-making by professionals. However, as others have already indicated to the hearing during the course of the earlier opportunities, there is a great discomfort by the fact that that legislation remains on the statute books, and with all that that implies, the whole area of being in contravention of the laws stands, and the possibility or the risk of legal action being taken against a practitioner. Would you like to just elaborate on relation to that? I presume you would confirm that there are no known cases, nevertheless, there is a powerful discomfort that needs to be addressed by the removal of that. And if I may, with just one last point that hasn't been referred to in the course of questions to yourselves, quite uniquely among the contributions made here today in relation to the composition of the review panel, you indicate from the Institute of Obstetricians and Gynecologists that you would look at the option of the chair of the review panel coming from outside of the medical profession. You indicate a willingness to accept that person coming from the legal profession. I think that that merits a little elaboration. It's not something we've heard from earlier contributions, and I think we would like to hear further on that, please.
And very briefly, Deputy Naughton.
Yeah, just very briefly, Professor McAuliffe, just coming back to the smaller units, we had the Master of the Rotunda earlier on, Sam Coulter-Smith, made the point that there was a need for a referral pathway to be in place for decision-making in the case of smaller maternity hospitals. Now, Dr. Nivedan, you were making the point earlier that, you know, and the current situation prior to reconfiguration, you would have another specialist in the hospital, maybe not an obstetrician, but another specialist. So I presume that your recommendation then is for option 2, that the sign-off would be for an obstetrician plus one other specialist. If that is your view in relation to it, or do you believe that there should be this pathway, as was referred to as in evidence earlier this morning? And just finally then, in relation to the issue of suicide, Dr. Mary McCaffrey made the point that none of her colleagues that she spoke for this morning felt that they were competent in dealing with making a decision in relation to termination on the grounds of suicidal intent. In those circumstances, do you believe that it should be up to the perinatal psychiatrist to make the call in relation to that, or should the obstetricians have a direct role in relation to a decision on that?
Thank you. Professor McAuliffe.
So to answer Senator Quaylon, we feel strongly that we need a legal framework within which to make our clinical decisions, and I feel that protects the public and our patients and healthcare professionals. Do we know of a case of maternal death because obstetricians were reluctant to act? We're not aware of such a case, but we strongly feel that we need legislation, a robust legislation to give framework to our work. In terms of the chair of the review panel, we discussed this briefly and we felt it could be recruited from either the medical or the legal professions, and that is our positions. We haven't come down strongly on one or the other. In terms of Deputy Naughton, just to sort of review the situation with the smaller hospitals, if a woman appears on a Saturday night to a smaller unit with severe blood pressure, this woman needs delivery, her life is in danger, that patient will be looked after. Okay, so I think that needs to be said very clearly. Our units around the hospital, we have lovely data from Professor Green. They're very high quality. The results are excellent. So in an emergency situation, you know, one specialist can make these decisions and can offer life-saving treatment. If time allows, the patient is unwell, but she's not immediately unwell, well then, of course, one could refer to a larger unit where perhaps there's more expertise. But in any unit in the hospital, if a woman in any maternity unit in the country, if she arrives in at the weekend, at night time, very unwell, needs delivery, whatever stage in pregnancy, she will receive that treatment. And that is part and parcel of running a maternity unit, no matter what size it is. And as Dr. Nibunan has alluded to, if a patient comes in and there's a bit of uncertainty as to whether she needs delivery, a second opinion can be sought by telephone. But that's why it's important that we have provision for emergency cases, that one doctor can make this decision to allow a woman's life to be saved. So in terms of the suicide, we feel at the Institute that 2 obstetricians should be involved in any decision to deliver a baby before or after viability, termination of pregnancy, or delivery of a preterm baby in the suicide case. So we feel that any case where there's a substantial risk to the life of the mother, that 2 obstetricians should be involved in that decision, suicide, medical, whatever the indication is.
Dr. Benin, do you want to make a comment? No, you're happy enough? Okay, thank you. Okay, Mr. Professor Green.
Could I just make a comment on, I suppose, with respect to slightly as a practicing obstetrician to Deputy Quaylen, you asked about the 1861 Act, and I think that I'm not aware of cases, but I am very aware as a practicing obstetrician of the difficulty that this does for us on a regular basis, and it is not uncommon that people working in the unit have concern about, for instance, the constitutional equal right of life to the child. And that does come up as a discussion point when you're making these very, very difficult decisions. And I think that's why we need the legal clarity around this issue. The other area is that it's very easy to make a decision if a mother's going to die of excess bleeding or blood pressure or whatever to deliver her now. What's not very easy is where, yes, there's a threat to the life, but it could be some weeks or months down the road.
Senator Burke,
just very briefly, just to clarify, you're saying 2 obstetricians to decide in the issue of suicide. Am I correct? And are you saying 2 obstetricians and 1 psychiatrist? Because the expert report gives a different option. It gives 3 different options, and it doesn't include that option. I'm just wondering, are we going outside the expert report recommendation?
Yes, we are. We are. We feel there should be 2 obstetricians who are on the specialist register making any decision if there's a substantial risk to the life of the mother, plus any number of other specialties that are required. So if it's a psychiatric case, we may need 1 or 2 psychiatrists. If it's a liver case, we might need a liver specialist. If it's a heart case, we might need a cardiologist and a cardiac surgeon. But in any situation where there's a substantial risk to the life of the mother, where termination of pregnancy or delivery of a very premature infant is required, we feel strongly that it's 2 obstetricians on the specialist register involved in that decision.
Okay, thank you. Okay, we'll move to the session of 20-minute duration from non-members of the committee. And Senator Walsh, I missed you earlier in the last session, so I'll take you first this time. And my apologies for missing you earlier.
Thank you very much, Chairman. I'm grateful to you. Can I start by saying that as we come to the end of the first day, I think there's one thing we can be reassured on, is the very great degree of confidence that there is in the quality of our maternal health care. And I'd certainly like to acknowledge that. Mr. Green, in fact, started by saying that women availing of the very high level of health care here, and I must say I welcome the obstetricians and gynecologists statement that our outcomes here, in fact, and our maternal health care is favourable with the best international comparators, and I think that's very welcome. Can I just ask the obstetricians in relation to some of the questions that have been asked, but this particular one about a duty of care, do you think that our current 2-patient model is something that we should try to preserve going forward, and that there would be a duty of care, obviously, to the baby in any legislation that's brought in? Secondly, in relation to legislation, and I think a number of the groups made the point that they were anxious for repeal of the 1861 Act. Do you think, if that's repealed, that there should be sanctions in certain circumstances for illegal abortions? Can I move to the IFPA position? And can I just ask the IFPA, could you identify any circumstances which occur in the international countries that you talk about where you would disallow abortion, or would you allow it in all circumstances? And can I also just ask you, do you consider that the unborn child is entitled to protection within the system and also within the legislative framework in relation to the issue?
Thank you.
Can I just...
Sorry, go ahead.
Have I time for...
Yeah, you have. Yeah.
How long have I?
Go ahead.
I have 2 questions.
You, yeah,
I have 2 minutes?
You ran your
very
2 minutes.
very quickly, can I say, and I think I picked up correctly, Mr. Bean, that you said that doctors are prevented from giving women best care. That would fly in the face of everything we've heard this evening here and everything that we've heard previously. Would you like to reconsider that in relation to those comments? Or could you give us evidence-based, now not opinion-based, but evidence-based reasons for that if you're not resigning from that position? My final question is, on this one, Mr. Sam Coulter, an eminent obstetrician who was before us today, said that such practices could put women's life at risk. He was referring to the investigation which is currently underway in relation to your association. Would you like to take?
Speak
No,
about
just
that
asking.
sorry,
Would you like to take
sorry,
the opportunity
sorry,
to
Senator.
clarify?
Sorry, Senator.
To clarify
Senator,
that
sorry.
and make an
Sorry,
appropriate
Senator,
statement
you're out of
in
order with the
relation to
question.
which I think is
I'm
overdue.
allowing the question. Thank you. Deputy Flanagan. Thank you. Thank you, Senator.
Thanks, yeah. Thanks,
You're being unfair to the witness now and to the committee by that note, Senator Watts. It's not. Senator Deputy Flanagan. Deputy Flanagan. Our committee, for the record of the House, have discussed that and have. Sorry, let me just make the point. And we're awaiting an investigation, and when it comes back, you're being unfair. Deputy Flanagan.
Yeah, okay. Thanks, Kerry. Look, can I ask Professor Harrison in relation to the Institute, whether the Institute has consulted its full membership in relation to the expert group report, and what form of consultation would that process have taken? And to ask Mr. Behan of the Irish Family Planning Association, considering the low level of maternal deaths in the country, just wondering why you think Ireland is an unsafe place for a woman to be pregnant.
Thank you, Deputy. Senator Paul Bradford.
Thank you very much, Chairman. Very briefly.
So I can take all the questions together rather than